Dr. Prahlad, what is the way you get patients to be comfortable?
I didn't hear that. What is the way you get patients to?
Patients to be comfortable with you when they come in,
Okay.
because they either have, they'll be a little scared, or they could
Oh, yes,
be,
yes, yes.
wondering
So,
about, yeah.
the most important thing that I think doctors, which majority, almost 99% of the doctors in India miss out, is empathy and comforting words. Generally, in India, doctors find it very comfortable to themselves to scare the patients. So the first thing is to remove the fear in the patient's mind. The minute we remove the fear, that's 50% of the battle that is won, and the patients trust. Once they are not scared anymore, the trust is already built. And once the trust is built, then it's a matter of just going through the treatment. So the most important thing I think is to remove fear, not worsen the fear. They're already scared about their diagnosis, about the treatment, and all that. In fact, most patients come with a wrong impression of the worst. Everything is they already come with a, especially with the disease that I deal with. They already think it's already the worst case that anybody's ever seen. So it's all about reassurance. So in one word, reassurance is the one way that we should make them win their trust.
Okay. And when you're treating patients and getting their history, do you have a way of getting them to open up? Because I think what you touched upon in the beginning is very, very important, which is the empathy. How do you then
Right.
get them to talk to you?
Yeah. So again, a lot of doctors have, at least the newer generation doctors, are missing out on this. No matter how much of training we have gone through our formative years in medical school and during training, good history is 70% of the diagnosis. So we tend to get the minute now patients come into the room, the first thing a doctor wants to see is the scans. Even nowadays, patients also come in, offer their reports, blood test reports, and scans. I mean, there are gone are the days when doctors actually nowadays 70% of the times doctors don't even touch the patients. I don't know if they still examine. They put them onto an examination couch and examine and be very systematic about it. So history taking is extremely important, and just being patient and listening. Again, Indian doctors, majority of the Indian doctors don't have the patience to hear. Some of them don't have the time, which is absolutely wrong. And I mean, if somebody has come under your care, the doctor has to make time to his or her practice should be just enough to make sufficient time for the patient. It shouldn't go beyond what the time allows them, to give sufficient time for the for each patient. So giving time to the patient, listening to all their symptoms, not just treating reports, treating the whole person and the whole family, because the whole family is in it. It's a journey for the whole family. So that these two things are as important as the treatment itself. The taking into the confidence the whole family and listening to the history carefully. And not only that, we can offer the most expensive treatment, but we know some patients cannot afford, simply cannot afford it. So we have to customize in India still. Though we always talk of evidence-based medicine, sometimes it's a little bit of economy-based medicine also. We need to factor in the economy as well, especially when we are talking of patients coming from lower socioeconomic status.
Okay. Welcome. Today, I have the honor of hosting Dr. Prahlad Yatiraj, who's an oncologist with an extensive clinical training background across globally renowned institutions. He has worked with several renowned hospitals, both in India and abroad. He holds an MD in Radiation Oncology from Madras Medical College and a diplomate of the National Board of National Academy of Medical Sciences. He also serves in key academic roles. He's worked at Kasturba Medical College and at the Tata Memorial College in Mumbai. Today, we're going to talk to him about what a career in radiation oncology is about, because it's one of the ways in which cancer is treated today. And we'll figure out what a career in this field means. Dr. Prahlad, wonderful to have you on the show. Thank you
Thank you.
for
Thank you so
joining
much.
us.
Yeah, it's my honor.
Okay,
Absolutely.
okay. So, what does a typical day for you look like?
Okay. The day for a radiation oncologist, since I'm representing the field of radiation oncology, I'll speak on behalf of the field, not just me in person, also me in person, but also as a field. So there are two primary institutions. One is a private hospital, a corporate hospital, like where I work. And of course, I've also worked in, and there are a lot of doctors working in um, medical colleges, teaching institutions, teaching hospitals, or government hospitals. So a typical day in a radiation oncologist life would be uh, so it's either outpatient, where we see new patients who have been referred for radiation. We see the new patient, take the whole history, study the reports, and then come to the diagnosis is usually already there. It's a case of cancer, and that's why they've been referred for radiation. So we evaluate whether there's a role of radiation, what is the role of radiation, whether it's a curative case or a palliative case. Then we explain to them accordingly, and then once explain to them the benefits of radiation, the side effects, the cost if it's a private hospital, the costs involved, and then so that is seeing new patients. Next, you would see some old patients who come on follow, who finish the radiation, and who need the all cancer patients for at least 2 years have to be on very strict follow up. So we see patients who have completed treatment and who are on regular follow up. Some of them just for an examination, some of them with scans and blood test reports. The third set of patients whom we see are patients who are on treatment. So about 30, 40 patients usually under any consultant would say 20 to 40 patients are usually under one consultant. And so the consultant's doctor's responsibility is to see those patients who are on under their care, see how the treatment is going, assess for side effects, counsel them, look for if the diet is changed, if there are any symptoms, and manage those symptoms. So there are new patients, there are old patients who come for follow-up, there are on treatment patients whom we review. So this is the outpatient work, and um, the rest of the work predominantly happens in front of the computer, where we are very closely involved in planning the radiation. So when I refer to planning radiation, what essentially we do is the once the radiation, say the first set of patients who I mentioned, they are the new patients who need radiation. So we explain to them about radiation, then they go for a radiation scan, a special CT scan after a mold or a plastic mold is made around them so that they don't move and all the markings are made on the mold. And a special CT scan is taken. And once that CT scan is taken, the radiation planning takes place. So, what essentially radiation planning is that we identify the tumor. So, it's a lot like surgery, just that the surgery is done on a computer in front of on top of a CT scan. So,
Okay.
what the surgeon would do is he would cut out the tumor. In case of a cancer surgeon removes the tumor and he spares all the normal healthy organs that is there. So, a radiation oncologist predominantly does the same, just that on a CT scan. On every slice of a CT scan, the radiation oncologist would mark out where the tumor is, where the potential spread of the cancer is, and also mark out the normal important organs that are there, which should not get the radiation. So it's essentially marking out the tumor, marking out the areas which are where the tumor might spread, and also the critical organs. And we come up with a plan iterative plan that we run iterative plans with the help of a radiation physics department. So a separate department, and that department would tell us, we'll come up with a plan of the best plan of how to give maximum dose to the tumor and give minimum dose to the normal structures. So every organ has its own tolerance, and we keep the tolerance, we keep the dose below the tolerance limit for each organ, and we know the dose which is required to kill the cancer. So we come up with a plan. So that takes up a good chunk of the day. Almost 2 hours per case, or 1 to 2 hours per case is spent in making the radiation plan with the physics department.
Okay. So, if you could, in layman terms, explain when surgery would be recommended, when radiation is recommended, and when chemotherapy is given.
Yeah. So there's no one answer for this question. So if we take, so every tumor and at every stage of each tumor, the treatment is different. So if we look at brain tumors, it is surgery followed by radiation with tablet, oral chemotherapy. If we look at oral cancers, very early stage, just surgery alone is enough, or radiation alone is enough. If it's a little larger tumor, we need surgery and radiation. If we look at the tumors in the back of the throat, the oropharynx, or in the foot pipe, upper part of the foot pipe, or in the voice box, just radiation alone is enough. Just radiation with chemotherapy. As you go lower, if it is, say, a breast cancer, we go with first chemotherapy or first surgery and then radiation in the end. So there's no space for, there's no, it's not, we're not fighting for
Division
space.
between one and the other.
Yeah, we
Okay.
are not fighting for space amongst each other. There's a clear cut role for each oncologist in every cancer. So in most of the time, or most of these cancers get discussed in a tumor board where all the doctors are sitting, and they would we would come up with the best plan for a patient. Sometimes there are straightforward cases where we don't need to depend on a tumor board, but difficult cases almost always go through a tumor board.
So, what is a difficult case? I'm trying to understand what does it mean. Does it mean that there are several treatment modes and doctors will have to confer in order to figure out which is the best way forward?
Yes. So not all cancers follow textbooks. We only read textbooks. Not all
Right.
patients follow textbooks. At least the disease and the way they present. And so, if it's a, as I mentioned, if it's a straightforward case, if it's a breast cancer, third stage, surgery has to be done, chemotherapy has to be done, then it's straightforward radiation. No doubts. Such a patient, nobody contests whether radiation needs to be given, it has to be given. But if it is a early tumor in the back of the mouth, and whether surgery needs to be done or radiation needs to be done, both are equally good options. Then we take into account the quality of life of the patient, the finances, the which would be less harmful to him, which would give a higher chance of cure. So we weigh in all of this, and in the meeting we would discuss, and then we would come up with a plan. And some cases are really tough, in the sense they have come back, the cancer has come back. Sometimes we need the collective experience of several doctors to come up with the best plan. Somebody would say that, no, I've seen such rare cases before. It's best we start with chemotherapy rather than radiation. So sometimes at some junctures, when we are not sure whether the first step should be radiation or surgery or chemotherapy, at that time, tumor board helps in deciding what's the best next plan.
Okay. In the last couple of decades since you have um, become an oncologist, what are the kind of changes that you have seen in treatment modes and how cancer generally is handled?
Yes, great question, Atul. So, in fact, it is about 1.5, 2 decades that there has been revolutionary advancements, not only in radiation oncology, the field that I am a specialist in, also in chemotherapy. Chemotherapy has not changed much, but immunotherapy and target therapy has changed a lot and has become affordable and available and affordable to our patients. And surgery in the form of robotic surgery. So tremendous advancements. The basic um, principle of all these advancements is the same, that we want to make the treatment safer and more effective and safer and more tolerable. So you can imagine a surgery to the abdomen. This is something which a layman can easily understand. A surgery to the abdomen in the past would be a big cut, 25 centimeter cut on the abdomen, um, and then that means about 7 days strict bed rest, and then another 10, 15 days later the sutures are removed, and then there's always the risk of infection, hernia. Say 10 years later, it could lead to a abdominal wall thinning. It can lead to hernia. It
Right.
has its own complications. So then came advancements in the form of laparoscopy, a keyhole surgery, where we just use three ports and enter. So on the second day, patient is up and walking. Third day, patient is back home. So you can imagine how advancements, the same surgery, the same, everything is the same. Internally, that's happening. The surgery, the amount of tissue that has to come out is coming out. Whatever has to be preserved is preserved. Just that it is way more acceptable and easy, and easier on the patient to take it. So same
The
advancements with radiation.
okay.
Same
No, please go
advancements
ahead.
with radiation. Okay, sorry. So the same advancements with radiation. Earlier, the entire area in the past would get full dose of radiation. Whatever normal organs that were there in the path of radiation would get the full dose, and we're sure that it would undergo permanent damage. If the lung was within the treatment area, the lung would get completely damaged in that area. If it was the heart would go weak after the radiation. If it's the salivary glands, they be permanently, they won't produce any saliva. So advancement has come in this form of being more precise. The radiation is way more precise, more focused, and the radiation, almost the high dose radiation, never touches some of the critical structures, which is a little further away from where we want to treat. So the side effects are very less. Now, recently I had a 94-year-old patient who finished radiation for cervical cancer. She
Wow.
finished full 25 days of radiation and two sittings of internal radiation. 6 months later, she had invited me for her great grandson's wedding. I attended the wedding. I was I was
Wonderful.
honored very nicely because she was very insistent that I attend. So I attended, and then the whole family was around, treated me like a VIP, which I am not. So the thing at a point I'm trying to make is even 90-year-olds uh, can now safely receive radiation and be done with it and
Okay.
get on with a normal life.
Let me ask you another typical layman question. The 25-inch incision that used to be made is now done through keyholes,
Right?
but the tumor inside has to be extracted. So, how is
Yeah.
that done?
Yeah. So then there'll be a smaller nick somewhere else for the tumor.
Okay.
Sometimes they use one of the natural openings. So
Oh,
if it's the uterus which has to come out, then a small nick is made in the vaginal entrance, and then it's brought
oh,
out, and
okay.
then the top of the vagina is fine. So
Wow.
it has its own place. You can't remove a 25 centimeter tumor through a keyhole surgery unless
Right.
sometimes what happens is they're filled with fluid. You puncture, suck out the fluid, then it just collapses into a small ball, and that can come out. You know, so yeah, that
Okay.
I leave that to the surgeons.
Yeah. I mean,
but
but
but there are ways to get around. Get around.
okay.
Now there
So when
advancements have
you
become so much. I'm sorry, I just finished this. Sorry,
so
the advancements
yeah,
have become so
no, so when
much.
you say more precise targeting, is it that every slice of the CD scan, you're able to figure out the affected area, and then you're
Correct.
literally able to map it out and then say, okay, only here and not out of there, which is
Yeah,
the kind of precision you can get now, which you couldn't get earlier? Is that
yeah,
roughly how it
very
works?
much. Yes, very much, very much. Yeah.
Okay.
So
Okay.
we do what is known as stereotactic radiosurgery, where we treat
Okay.
a tumor which is the size of 7 millimeters. So
Okay.
a tumor which is 7 millimeters somewhere
Wow.
in the brain. Uh, we give another extra 1 millimeter margin, and we would treat it with very high dose of radiation, very high dose of radiation. So, so even a tumor which is say 25 centimeters can be treated with radiation. Even a 7 millimeters, a 5 millimeter tumor, if it's visible, it can be treated. So, so a small
Okay.
tumor also can be treated with the same machine and the same technology. The technology is a little
Okay.
more advanced, but that's the power of radiation. If you can see it, you can treat it, and you can possibly cure it.
Okay. Great. So I'll just make the announcements and come back.
Yes.
You've been listening to my conversation with Dr. Prahlad. And during this segment, he spoke about what a typical day in the in meeting patients is like. He talked of how you managed to figure out the diagnosis is important, and then you have to figure out the exact radiation area that needs to be isolated. And he said that this is typically done in terms of, especially the more complex cases are handled by conferring with the other doctors. And it's almost as if doctors have to work in tandem in order to ensure that the patient gets the most benefits. He spoke of how in the last couple of decades, treatment has got a lot more targeted, it has become a lot more precise, and it allows for faster recoveries and for more precise dispensation of whether it's the drug or the surgery, because of robotic surgery that has also come in a big way. In the next segment, I'll be talking to Dr. Prahlad about what how his own journey in medicine started and why he chose oncology, because it means that it is a pretty, at one point he spoke of the successes, but there are also points at which you can't be 100% sure. So what is it that goes through the mind of a person who is looking to get into a certain specialization and then see where it goes? My name is Venugopal. I head Ideascape. And every week we speak to professionals from different fields. And the idea is to get them, anybody who's watching, to understand what the career actually involves, rather than just, we understand radiation oncology by reading something on the outside. But by getting somebody who's so experienced, we get to know what their life has been like. So, Dr. Prahlad, what is your own history? Where did you start? Was medicine
Ah,
the only thing that you really looked at, or were there other career options that you considered? Where did it begin?
oh, yes. Thank you for that question. So in 1999, my yeah, late 99, early 2000, start of the millennium, actually, my grandmother, she was a patient of heart failure, and she was at middle of the night. She started calling out to us, and so we all rushed in from our bedrooms, middle of the night. She was having a heart failure. Her feet was cold, her hands were cold. We had to call she was suffering. We had to call in the ambulance. At that time, I felt helpless. And that day, I mean, I don't know, I was in my 10th standard. It was that the spark that I needed. And that day, until then, I was a fairly average student. I was not doing so well as well. And that day, that sparked me that in me that I shouldn't feel helpless. At least I should know what to do. So that spark ignited my thought that I should become a doctor. That was 10th. I scored very well in 10th, and then got a college seat on merit. In 12th, again, I got a one. It's like a catalyst. I had a that was a catalyst. I was a newer person. I was a better student. I did well in my 12th. I got a merit seat. I paid 14,000 rupees per year for my annual MBBS fees, which is now crores. Everybody talks of crores, but I spent 60,000 rupees for 5.5 years of my education, which I anyway earned back during my internship. So it was a merit seat. I studied in Mysore for my rank that year. Somehow that was the year Y2K had come in a big way. So all the colleges in Bangalore had had gone. There were only three colleges in Bangalore back then. So I was happy to go to Mysore, and it was a hostel life. I was also keen on exploring hostel life. They say it's a new education in itself.
Right.
So I went to Mysore and did very well. I met my junior, who is now whom I'm happily married to for the last 15 years. So a lot of good things came out of that college that I was there. So then, when did I take up oncology? Is in every time I read any subject, say whether it is pathology or in pharmacology or in ENT or in ophthalmology. So there are separate subjects in our medical school. Second year is pharmacology and pathology and microbiology also. But in all these subjects, in third year is ENT and ophthalmology and community medicine. Final year is actually surgery and medicine. What interested me the most is when I got to the in the textbook, when I got to the point of, when I got to the chapter of the cancer. That's what excited me and interested me, and I wanted to be a specialist in that field, which is going to evolve with me. So a lot of medicine was already well known by then. You take Though, of course, medicine is constantly evolving, but if you take a field like, say, cardiology, nephrology, a lot was already known by then. Oncology was relatively unknown. I'm talking of early 2000s. Lot was changing in the field of oncology. New technology was emerging. So I wanted to take up a field where I would evolve with time, and the specialization also evolves around me. And it's a great decision because just then, this machine called linear accelerator is the new machine which back then was the new machine which was delivering radiation. Till then, we only had these cobalt 60 machines which are really giving radiation to the entire area and burning the whole tissue. But linear accelerators got introduced in late 2000s. They were mushrooming in the whole country. Same time I joined, in 2009, I joined my MD in Madras Medical College. And the field virtually grew with me. As my experience increased, the everybody was starting fresh at 2012. When I started fresh after my MD, almost the whole city of Chennai or the whole country was starting fresh in this new technology. So being young, I could grasp, and I attended a lot of conferences, meetings, learned from several seniors, went abroad for several training meetings and training both in the University of Michigan as well as in Princess Margaret Hospital in Toronto. So yeah, very fulfilling career so far, and looking forward.
Absolutely. You have kept pace not just with your own specialization, but in also in terms of teaching and presenting papers about the. So, what are the things about teaching that you like, and how do you decide which of the cases that you want to document?
Yes. Uh, Unfortunately, in the last 4 years, once I've come to a corporate hospital, private hospital, the uh, willingness to and we are not expected to publish. If you're in a teaching
Okay.
institute, there is a necessity that you need to publish and present in meetings and
Right.
conferences as a
Right.
part of incentivize their promotions and so on. But that requirement is not there in a private hospital. We just have to take care of the patient who's sitting in front of us, take good care of them. That's the only
Right.
requirement. But teaching is rewarding, and presenting. So it's very important to document what we have done. This is the reason why Western medicine is so popular and so good and so well accepted all over the world. And say, over one of the Indian streams of medicine like Ayurveda or homeopathy is because of very good, diligent recording of what happens when we give a medicine, what are the side effects, what is the benefit, what are the, I mean, we everything is documented. So if the data is collected well, honestly, and documented very meticulously, then you have you then it's not just an opinion. So it is
Yeah.
just it is backed with science. So that's the reason why Indian medicine is still a little well behind Western medicine, is because they are not yet documenting diligently, and the data is not there for everybody to evaluate for themselves. So
Okay.
that's the importance. That's the importance of recording data and presenting, so that somebody else also learns from your experiences. So and that's how we all learned, and it's a way of giving back, not only to students but to others who are faced with a difficult case. When they look up the internet, they find somebody else has done this particular treatment and they have been successful. It gives them the confidence of trying it out for themselves. I'm talking about difficult cases, not the straightforward cases.
Right. It's somehow a little, um, I don't know the correct word for this, but it's very often the cases that are frustrating, which are often the most memorable as well, because the ones that allow for a straight diagnosis are probably easier. But when you have to uncover and then, figure out what the issue is, so it can be both a source of frustration, and then when you manage to crack it, or it becomes a much more fulfilling, especially when you're able to
Absolutely,
help the patient.
absolutely,
So,
absolutely. So
what are the kind of cases that, as far as you are concerned, have had that? You mentioned about the 95-year-old whose salivary glands, you were able to treat. So, along the way, what were some of the early cases that?
yeah, so normally children below the age of 6 years would need general anesthesia. They don't cooperate for radiation, and I've treated fair number of children. And what I of course, after reading, we constantly keep reading to update ourselves. Also from the reading and also from personal experience, what I realized is children after, say, the fourth day. So it's children are scared of the unfamiliarity and a new place. The thing that brings fear in children is unfamiliarity, and if it's a new place. So what I when I started treating children, I would start bringing the child before the treatment starts. Also, bring them into the treatment room. Make them see the treatment area, show them the mask that we are going to make, um, and bring a sense of familiarity to them, so that they are less anxious. And by so that way, we could treat a 3.5-year-old child without general anesthesia for 30 days of radiation. And by the third day or fourth day, so the first day the child was crying a lot, so we abandoned. We didn't even start the treatment. Second day he was crying lesser. Third day again we didn't treat. We just everything was in a simulation mode, kept everything ready. We didn't treat. Third day, fourth day. By the fifth day he was calm, and from the fifth day onwards we started the treatment. And from the fifth day he knew this is the exact sequence. He's going to come into the radiation room, he's going to lie down, we're going to put the mask over his face, we're going to put the mask over his body. We had to treat his brain and his entire spine. It's a very challenging brain tumor. So this is the exact sequence that is going to happen. Now it's not unfamiliar anymore. He knows he can hear his mother outside on the speaking on the mic. So once children are familiar, and the remaining 30 from day 5 till the last day of radiation became such a breeze. He became so friendly. Every one of all the nurses, all the technologists, we all fell in love with him. He was very cheerful throughout his treatment. He was very cheerful. And we used to give him toys every week. We told him, if you do this, then this week this is your toy. So things like this, it's never straightforward. Cases are never straightforward. Some days elderly, some days young, some days young 30-year-olds, 40-year-olds with cancer. You feel for them. Sometimes it's just not their fault. It could have been us. It could have been me, uh, who's there sitting across the table. So we do our best. It's not easy, but good thing is over the years you learn to be. I would say you tend to dissociate yourself. You don't get emotionally attached, so that be dispassionate about the work, so that that's what they also look for. If you're also equally emotional and you also start feeling bad for them, then it doesn't help. So you want somebody to dispassionately be steadfast and get on with the treatment. So it's not easy. Not
It's
every day
that
is a
fine
new
line,
challenge.
what you just spoke of, you start when you said empathy and then being able to be dispassionate. It's a very fine line. So you
Yeah,
need empathy, but you need to be dispassionate as well because it shouldn't go overboard. It shouldn't get to the
absolutely
point where they get dependent on this.
correct.
And that professional sort of distance, it's amazing how in practically every profession the basics you can learn in 6 to 8 months, but the nuances take a lifetime. You
For sure,
can,
for
you
sure.
know, you can kind of understand, okay, this is what it means, but all the other stuff that you have to deal with and how exactly. And I'm sure in a lot of the cases, you're making up those decisions as you're interacting.
Hundred
So, will
percent,
the parents be
hundred
able to
percent,
take up something like this? Will the child
100%.
respond to? Because based on what your judgment is,
Exactly.
that's a
So
very fine
sometimes
line.
friends call and say, this is the these are the reports. What do I tell them? I say, see, I cannot. Sometimes it's straightforward. I tell them this is the treatment you suggest to them. Sometimes I say, no, I have to see the patient. I have to see the family. I have to talk to them. Only then I can come up with a radiation plan. So sometimes just exactly as you said, your point is absolutely true and valid. That sometimes while talking to the family, we get out, the things get clear out. As you're talking it out, the plan gets, takes shape in our minds as well. Very true.
So, why does sixth sense improve? I mean, you call it sixth sense because you're not able to put a finger on it. But typically, the more you experience, the more you're able to figure out exactly what it is because maybe the signs are not showing up in the actual tests that you're doing, but somewhere at the back of your mind, you're saying that maybe this is what it is. Why do
Yes,
you think it happens?
I strongly feel humans have an additional sense which has been curbed over the years just by because the other senses are just overpowering this particular inner sense that we have. The vision is so much. We depend so much on vision, a little bit on what we hear, and of course our speech and our thoughts and everything. Everything else is overbearing. That the other sense, sixth sense, which you're referring to, is is kept mellow and suppressed. So sometimes, luckily, it kicks in. With more experience, you tend to know. Once you've made mistakes and you know when not to. That's when the sixth sense also gets better. You sometimes you know when to not push the patient for treatment and when to back off. Uh, yes, it comes with
Yeah.
experience. That's the importance of age and experience.
And you've seen the prevalence of oncology increase. They come under the so-called category of lifestyle diseases. So, or is it that human physiology itself has changed because of the environment? What is happening?
Unfortunately, nobody has a concrete, confirmed, firm answer for that. Why cancers are increasing? We could only speculate that a lot has changed from what we're not leading the same lifestyles as our parents and our grandparents did. So our parents' generation saw a slightly higher risk of cancer. We are seeing a slightly higher, even more higher risk of cancer. So there is no one particular cause for cancer. We all have genes for cancer. They're all kept suppressed. But at some point, one gene gets mutated. It normally thousands of mutations happen in our body every day. everything gets rectified. The body has a great repair mechanism. Sometimes when there's more stress, by stress I'm not saying external stress from the anxiety and stuff, but internal stress because of smoking, drinks, lack of sleep, obesity, red meat, too much red meat, too much anxiety, anything too much, anything in excessive is bad. Even sugars too much is bad, salt too much is bad. So everything, anything in excess, it leads to some stress. One of these mutations do not get corrected. One mutation leads to five more mutations. Five mutations leads to 50 mutations, and finally, it eventually it one cell becomes an abnormal cell with accumulating a lot of mutations, and one cell becomes a fairly big cancer. That's when it starts showing symptoms. So now, what is the reason for initiating the stress? I mentioned a lot of them. Now, who is at risk, who is not at risk? There's no way to tell. So we all have the risk of getting cancer. All of us have the risk of getting cancer. Only few of us get it, thankfully. Um, so um, exactly what is inciting the event, the cancer formation event, is still not known. But broadly speaking, we can say the lifestyle is worse off than what it used to be. That could be, plus the external pollution and external influence, and a lot of it is attributable to formation of cancer.
Okay. So I'm speaking to Dr. Prahlad, and during this segment, he spoke of what his own experience of oncology has been, and the start of his career, where he said he felt helpless when his grandmother was had to be hospitalized late at night, and he sort of made a decision that he would never want to be in a position of that kind of helplessness again. And things did work out. He scored great marks. He got into medical school. And the reason he chose oncology was, he said, because he felt that this is a field which is evolving, that there is a lot of new knowledge to be gained, because some of the more established fields like cardiology and neurology and orthopedics have a lot of work has been done. But oncology is literally the kind of problem that today's society is dealing with, because there is a lot more incidence of cancers. And like he said, it's not, you can broadly classify it under certain things, but there is no single way that you can figure out that this is the exact cause. In the final segment, I'll be speaking to him about how he sees his own career evolve from here. What is it that oncologists coming into the field today would do uh, well to understand and prepare themselves for? And ultimately, a doctor is someone who's looked up to in society because of the kind of power that they now wield over health. And it's amazing how much of effect they have on the way that we are treated and how society itself has evolved. So, Dr. Prahlad, what is the kind of things you see going forward? What are some of the treatment modes that you see have developed over the past couple of years or 3 years, and what is it that you see is in store in the future?
Okay, so immunotherapy is a type of treatment where there's a medicine which is given through the IV, and that medicine does not touch the cancer one bit. What it does is it unmasks the so cancer cells have the ability to escape our white blood cells, the T cells, that is the killer cells. The T cells are, there's a particular form of T cell which is called the killer cell, and that kills any abnormal bad cell. Now, the cancer has masked itself and made it look like it is part of the body. It's not a foreign cell, though it is an
Right.
abnormal growth in the body which is not meant to be there. So now, this new immunotherapy unmasks that cover that the cancer cell is utilizing to escape the killer cell. So the once you give the immunotherapy, it is not even a therapy against the cancer. It is just an unmasking therapy. So this essentially unmasks the cancer, and the cancer cell can the killer cells suddenly identify the cancer cell as foreign cell, attack and kill the cancer cells. So now in the last 4 years, we have started using immunotherapy. It's about 15-year-old, 10-year-old technology, 15-year-old, 10-year-old from the trials started publishing. About 5 years since we in India all had access to it and started using it. Cases which we had deemed as incurable, going to die in 3 months, hopeless cases, suddenly patients are living 2 years, 2.5 years, 3 years, healthy, normal life, not just just surviving with the tube in the nose, tube in the urine area, not just a healthy, absolutely healthy, normal life. So immunotherapy has been phenomenal in that. Not everybody benefits. 4 out of 10 patients benefit out of immunotherapy, but those who benefit in a way it is unseen so far in the last 5 years. I mean, it changes the natural history of the disease completely and changes our perception of the way cancers have to be seen. So nowadays, nobody should tell a patient, you're going to die in 3 months, go home. That it should not be the option anymore, because we just never know. That's how it's become with immunotherapy. Radiation has become way more accurate, way more focused, newer areas where we can treat. Earlier, we felt some cancers we're not going to treat. Liver cancer was thought as a never going to be treated area for radiation oncologist. 2018, new research came that you can use radiation. 2025, 24, a big paper was published by one of my mentors whom I trained under in Toronto. She published a big paper, and now liver radiation is coming up in a big way. I myself have been fortunate to treat several patients with liver, and some of them have done phenomenally well, gone on to have liver transplant. And so hitherto incurable cancers, suddenly they're doing so well, and you can never tell anybody that they're not going to make it, and until you actually start the treatment and see how the response is in the first 3 to 6 months. So that is
The
one way.
immunotherapy you spoke about, it's a very interesting thing because it's not about killing. It's about wearing down the cancer cells' own protection mechanisms.
Exactly right.
So
That
it's coming at it from an
is
angle that
that is
was not
phenomenal.
hitherto. Yeah.
Absolutely.
So it
And
is
there's
a
this particular
wonderful
type
way
of
to.
cancer. Exactly.
Yeah.
And there's this particular type of cancer, rectal cancer. So in the past, rectal cancer had to be operated and radiated to be cured. And then this particular type of rectal cancer, uh, they found only 3 or 4% of the rectal cancers have this mutation. They found that let us start with immunotherapy. After six
Okay.
months or 3 months of immunotherapy, they found the cancers have vanished completely. 6 months after the cancer completely vanished. They did this for
Wow.
one patient, it worked. They did it for 5 patients, it worked. They did it for 75 patients. All 75 patients had complete vanishing tumors,
Remission. Wow.
complete remission. And now that trial has the longest survival is about 4 years out. No surgery, no radiation, no chemotherapy,
Okay.
no immunotherapy.
Which is amazing.
Yes. So, in fact, there is a particular type of cancer called rectal cancer. And this rectal cancer in the past had to be cured only with surgery and radiation and chemotherapy. All three had to be given to cure this particular type of rectal cancer. And this rectal cancer, which has a particular mutation, only about 5% of rectal cancers have this mutation. In this rectal cancer, if this medicine, they started off giving this immunotherapy, They gave immunotherapy. They saw tremendous reduction in size in the first three patients. Then they said, okay, let's just give this immunotherapy and see whether even we need to operate or not. So first few patients got this immunotherapy. Then they waited up to 6 months. There was no recurrence. Then they increased the number of patients. First three patients, all three had complete remission. 10 patients remission, 50 patients remission. Now the latest, the trial has recruited about 75 patients. All
Wow.
75 patients have complete remission, no surgery, no radiation, no chemotherapy. We could not even imagine this. Even the senior oncologists could not have imagined that in their lifetime they would see some treatment for rectal cancer where without surgery, without radiation, without chemotherapy, 100 out of 100 patients, percent of the patients are getting cured of this particular cancer. So then now the first oldest patient's about 4 years out into this treatment and still no recurrence. So it
Wow.
completely changes the nature and the natural history of the disease. That is phenomenal the way science is advancing in cancer treatment. We're really hoping that it becomes more and more cancers get come under this umbrella.
So, do you think that immunotherapy has the potential to be applied to several other cancers as well, or
It
is
is.
it
It
it's
is
work in
already. It
progress?
is. It is already. It is already. But it's very much work in progress. As I mentioned, only 4 out of 10 patients respond to immunotherapy. And even in this immunotherapy, some when there is a response, then we find newer areas of radiation. So there's a small area which is increasing. Then that area is called oligo progression. Oligo is a medical term which refers to little or few. So oligo progression. In few areas, the cancer is not responding; it's resisting, and there is resistance, and it is growing. So in those areas, only we would give the radiation. So uh, radiation itself, there is constant change in the newer ways, newer locations, newer places where radiation is reinventing itself. So uh, science is evolving, ever evolving.
Right. Okay, so people who are doctors who are looking to specialize and then get into oncology, what are some of the things that you would tell them? Because the other part which I've not got into is typically this episodes on careers, people want salary bands, but I'm not getting into that because I think when it gets into something like this, or do you feel that it's worth talking about that as well?
100%, 100%. It's worth talking both about oncology as a future. You're reading everyday newspaper says cancer is going to increase 10%, 20%. India is going to have, so right now India is having about 14 lakh new cancers every year. They're saying it's going to be 20 lakh new cancers by 2035. World over, cancer incidence is increasing. Um, Again, we already touched upon what could be the cause. We don't know, but a lot of lifestyle changes predominantly. So, so as a field of medicine, yes, there is a need for oncology, and every city now is coming up. Back in those days, we had only about 5 cancer centers in the whole country. Then it became four, 3 or 4 cancer centers in the city. Now virtually every locality has its own cancer center. Um, so therefore, and then of course, unfortunately, it's all being crowded into cities. So Chennai has about 25, 30 radiation centers right now. It's a very busy marketplace. But a place like Tirunelveli has just one radiation center, which is a fairly large population. So if you see machine to population ratio, it's extremely unevenly distributed. So if somebody who's getting into oncology right now, especially radiation oncology, youngsters should be open to the idea of going back to those who take it from, who are originally from a tier 2, tier 3 city. For them, it's great because they can go back to your hometown. Those from cities may have to think of um, relocating to a smaller town initially, at least until you the opportunity opens up in your own city. And there's always place for good people. If you are a good doctor, you just need time, and uh, it's good people always find their space. So you just all doctors, I say that you just try to develop yourself. The system will find a way to have you. There will always be a place for you if you're good. So
Time after
it is
time, I've seen this that people who take the slightly lesser crowded route, like you said, the smaller cities, for them, the quality of life may not be the same as a metro. But in the long term, invariably, what happens is that you get to be a lot more involved with, and your practice grows. It might not be
yes,
at the same
yes.
salary levels as the metros to begin
No,
with.
in fact,
Then over
the
time,
salary is better in in a smaller city. In it is because in a bigger city, I mean, if I don't do this work, the hospital, let's say, I'll find somebody else for three-fourth your salary. So,
okay, okay,
there is a demand supply mismatch in the city. But in a
right,
smaller place, you're king. So you get the respect that others in the city wouldn't. So the pay can get better because not many people are willing to go there. So then they'll slightly increase the salary, hoping that somebody else joins. And so the pay is better. Your expenditure is lesser in a smaller city. So
yes,
you're left with more in a smaller city as a doctor than you
right,
would be in a big city. The only thing they fear schools and everything, but now good schools are coming everywhere, and family life
right,
can also
right, right.
can get better.
And life in a small town can actually be much better than the quality
Certainly,
of life can be
certainly,
a lot better than in a metro
100%.
as well.
Yes.
The other aspect is that how do you handle the stress of day to day? What is it that you
Yeah.
yourself have done?
So
Because I know you
I
love playing cricket.
yeah, cricket,
Yeah,
basketball, cricket, basketball, meet with friends, have a good laugh. Um so one thing is we don't take the work home. I don't
right.
discuss cases. I don't let it affect me because I mean affect me as in I don't let it affect me personally. If there has been if some patient has not responded satisfactorily, then you obviously introspect and see how you can do better. That way, I'm not referring to that way on a professional level, but on a personal level, I don't let the work affect me. I mean, we are the good thing about medical profession is you are there to help. Somebody is
Yeah,
not well, that's when you come in. If somebody is healthy, there's no place for us. We come in when somebody is really not well. So your mind, your thoughts, your focus, everything is towards getting the person better. So I only look at it from that way. If somebody is suffering, I try to do my best in mitigating the suffering as much as possible. If somebody's and whatever help in any way possible, I am there. So I only look at it that way. I only look at the positive aspect. I don't let it affect me in any way. So, of course,
yeah,
keeping away from work. In sometimes like Sundays are mostly away from work. So one day off completely. Cricket, basketball, 2-3 hours of away from the phone. Also, no social media. No,
right.
not even touching the phone for 3 hours. So all of that helps.
Yeah. In fact, this has become the other addiction, whether you like it or not, the phone, because a time when just making that call, the dial used to take so long that you invariably took every call. Now it's become a part of it's like an extended bit of yourself. So it becomes that much more difficult to ignore, and which I think successive generations will figure out their own ways of getting out of it. And it's already there where people are saying, okay, they go into a restaurant and they flip it over, and the first one who lifts it up pays the bill. So they found their own ways of dealing with it. So I guess we will find the change that happens over time. But in terms of what you have done so far in the last 20 years, at some point when you meet with colleagues who have opted for a different specialization, and then let's say they've progressed along neurology or cardiology or something else, what are the conversations about? I mean, what are the things that you, or is it normally about courses and
No, somebody who's 15, 20 years out into practice. conversation is all about how much you make, how much I make, how much somebody else makes. It's not, or interesting cases, difficult cases, and so on. But yeah,
Yeah, yeah.
and it's not about the past journey. It's about future, where you can
Right,
go,
right, right,
where is the opportunity better,
right.
it's
Yeah,
stuff
that's
like
true.
that.
And I guess that's this thing about social construct, which is focused on the here and now. Most conversations tend to be about what it's like today, what today's generation is about, what is the most interesting film to watch, which are the places to see, what are the kind of things that you. And I guess that's the other part with. Uh, I think I was talking to someone as to the concept of the GP, which used to be so common, let's say 20, 30 years ago, no longer exists because it's not as if
Almost
doctors
virtually,
get to
virtually.
know the not just the patient but the whole family, and they know the
Right.
history of the family. That is unfortunately, or
True.
I don't know, maybe it's just a sign of the times.
Uh, um, Nobody wants to go to GP also. Let's face it. If you have diabetes, you'll say, I want to meet a diabetologist. If you have heart, if you have blood pressure, I want to meet a
Right.
cardiologist. If somebody tells you it's a nerve problem, once you know it's a nerve problem, you want to meet a neurologist. So it's also demand supply. Patients are demanding, they meet a specialist, they are scared the GP may miss something, but then they're also scared a specialist may miss something, thinking it's their own, that some their specialty, but ends up being some other specialty because they're all interrelated. So yeah, GPs is still important. I still think GPs are important. They are there. It's good to have one family doctor who knows somebody who knows the whole history of yourself and the family, so they can take a step back and assess the situation from far, not be microscopically looking into what problem you have. Just take a step back and see the whole bigger picture and come to a diagnosis. That's only when diagnosis is tricky, but most of the time it's straightforward, so may not
Yeah,
be necessary.
yeah. No, I think you started off with empathy and then you talked of how, it goes over time, the experience that you get and how things have changed. So wonderful, Dr. Prahlad. It's been great talking to you. And
Pleasure.
here's wishing you continued success. And it's amazing how medical science continues to sort of advance and provide people um, more hope. Especially, there used to be
Yes.
a point at which people gave up or they sort of felt that nothing much could be achieved. But
Yeah,
right now, it's
especially
almost
with
as if,
cancer. Especially with cancer, people
yes,
give up hope, but not the case anymore. Not the case anymore. You have so many survivors, so many people to live, to tell their story, to give hope to the others. 2 days ago, a few days ago, we had World Cancer Day. 4th February was World Cancer Day. So, I mean, the awareness is the right things are happening in the whole world. Awareness is being created. So, it's not a disease where people need to fear anymore. Oncologists are doing well. It's a good branch. Radiation oncology is a good branch. I would recommend somebody who's taking radiation oncology. There is always place for good people. You must focus to get yourself better, and there's always place for good people. So we have to work hard to get ourselves better.
great. So, on that note, we will pause it here for now. Thank you very much for being on the show. It's been an honor talking to you and
Likewise,
getting
my
to know
honor.
your own journey and what you've done so far.
Thank
Okay.
you, sir.
Thank you very much. Like I
Thank you, sir.
said, please stay in the studio for about 4 to 5 minutes at the
We will,
most so that we
of
can.
course. Please let
Okay.
me know when it's okay to leave.
Right.
Yes, sir.
Thank you.
Thank you, sir. Thank you so much.
I was speaking to Dr. Prahlad, who's a radiation oncologist of repute who has had over 2 decades of experience, and his entire journey has been about understanding how the rarer and more virulent forms of cancer can be um, controlled and treated. He ended on a very hopeful note, saying that it used to be a terrible thing, but there is hope in practically every patient who is diagnosed with cancer today. On that note, we'll end for today. Next week, another guest, another career journey, and we'll be back with more. Thank you once again for watching.